California. As you know, the Affordable Care Act has two main ways of increasing access. One is expansion of Medi-Cal, and the other is the state health exchange. And this is going to have an effect on the state budget, on provider payments, and there'll be a lot of rules on the exchange that will affect insurers. And the big issue also is with the big expansion in Medi-Cal and also the state exchanges with the large number of uninsured in California. How is this going to affect access to care in California, given that the number of providers have not really increased proportionally to the expanded increase in demand? So we're very pleased to have the four panelists today. And the first one, Marian Mulkey, is the Director of Health Reform and Public Programs Initiative at the California Healthcare Foundation. And she leads the California Healthcare Foundation's work on analyzing the complex reform legislation and informing policymakers, state and local government, private stakeholders, and the public on ways to implement the law that will improve and expand coverage. So please join me in welcoming Marian Mulkey.
So thank you so much. It's a pleasure to be here. It's a very tough act to follow humor-wise, and so I'm gonna try to be helpful with content. I cannot live up to the humor challenge that some of my predecessors have laid down. So I'm going to try, here it is, to do a couple of things in my remarks today. I am really cognizant whenever I speak to a group that there are people all over the spectrum in the audience, and I am absolutely sure that there are some people who know more about some aspects of the Affordable Care Act than I do in this room, because every place I go, that's true. But it's also the case that every place I go, there are people who don't know things that I have sort of built into the basics of what I assume everybody knows. And so I'm going to try to strike a balance of laying some groundwork that puts everybody in the same context, giving a status report on where things stand from my perspective with respect to implementation of the ACA in California. And then I'm going to talk just briefly about a framework for monitoring developments in the era of the ACA going forward that CHCF has invested in. And then, because I'm an obedient person, I'm also going to offer a few things that I'm going to pretend are forecasts, but really they're more kind of commonsensical observations, which is one of the assignments that Margaret and Paul gave to us panelists. So I want to start with really, really basic stuff about coverage in California. This is a chart from the Legislative Analyst's Office, and it's just a reminder that while about half of us in California, non-elderly Californians, get coverage through employment, either our own or as dependent on somebody else's employer-based coverage, the rest of Californians don't get coverage that way. 7 million or so are uninsured. Another 7 million are enrolled in Medi-Cal or healthy families. And then about 4 million either purchase coverage through the individual market on their own, at their own initiative, at their own full cost, or get it through some other kind of public program or private program. The share of Californians who have coverage through employment has fallen a lot in the last 10 years. So this is 2011 and 2000, fell from 62% in 2000 down to about 52% now. At the same time, the share enrolled in Medicaid has gone up significantly. The share that purchases their own coverage through the individual market is pretty stable and probably really smaller than that right now, maybe 6% or so of the non-elderly population. A few non-elderly folks have Medicare or other public programs. And then again, we've got this 1 in 5 or more of Californians who are uninsured today. And that too has gone up, although it's been high for a long, long time. Why is it that we have less and less job-based coverage and more uninsured people or people in public programs? Well, this is John Gable's work. The employer-based coverage tells us that our premiums are going up far, far faster than the rest of our economy. And so both employers and workers and individuals, households, struggle to afford what it costs to be in coverage, even if they have an offer. And this, again, is a year-old data from the California Health Benefit Survey. which shows just how expensive it is. And again, John Gable mentioned these ballpark numbers, which again, $15,700 for California family coverage, clearly beyond the means of somebody who is low wage or minimum wage worker, if that's their only alternative. So it's against this backdrop that the ACA was passed at the federal level in 2010. And Paul mentioned some of the big features of the Affordable Care Act, which certainly has many different components, many different provisions, seeks to do many things. But I think many of us would argue that a central focus is to expand coverage. And it does that in many different ways. It has a substantial expansion of the Medicaid program. It puts in place insurance market reforms. And again, many of you may know this, but understand that the individual market today is not an inviting place. People cannot necessarily buy coverage there. They can be denied coverage based on health history. If they're offered coverage, they can be rated more highly, be charged more because of that health history. And once you get into coverage, you have very limited choices about moving to a different carrier or plan. And that, and the result of that is that not everybody who might benefit from that type of coverage participates in that market right now. There are, of course, new individual responsibilities coming in place. And again, all of these take full effect in 2014. The so-called individual mandate, where everyone's expected to obtain coverage either through their employer, by enrolling in a public program, or by participating in the individual market, either outside or through the exchange. And then finally, there's the insurance exchange, which is that structure that allows side-by-side comparison of options. The vision is that it will quickly sift people into whatever coverage option is available to them, with federal premium subsidies on a sliding scale for people who qualify. There are employer responsibilities too. I'll leave those for another day. Because Medi-Cal is, the topic of this panel is about the state budget, and because Medi-Cal is a big feature of both the ACA expansion and a substantial part of our budget, and I think Len's going to talk a little bit more about that, I just wanted to offer some observations about what's true about the Medi-Cal program today. And this is not unique to Medi-Cal. Medi-Cal is California's version of the Medicaid program, a federal-state partnership, and it's dictated, of course, by rules that the federal government states as well. So eligibility and income rules vary by population. So it is much more generous. Eligibility is much more open for kids and for pregnant women, for example, than it is for non-parents who currently do not qualify. The ACA will change that standard. There's a complex asset test, a lot of different rules about what allows people to be eligible or keeps them from being eligible for Medi-Cal. And then just a little bit of a footnote, there are many non-elderly Californians who are enrolled in Medi-Cal today, about 7 million, but there are also additional senior citizens and people with disabilities, people who are dually eligible for both Medi-Cal and Medicare, who are the responsibility or who receive their health care services through this program. So it's a really important central program that provides care and services for many, many Californians, including many who have great need. Provisions in the Affordable Care Act with respect to Medi-Cal. The income eligibility standards will be raised up to a uniform floor. So irrespective of whether you have kids or not, whether, whatever your age, if you meet a fairly simple income standard, you will become eligible for Medi-Cal in 2014, presuming that California enacts the legislation that will cause it to do, as our governor has indicated he intends to participate in the expansion. The standards for determining eligibility are much simplified. So there is a standard income test that is the criterion for determining eligibility in most cases. The expansion population is 100% federally funded in the first 3 years of the program, and then it ramps down to 90%. And we heard a little earlier about the states who are thinking about not participating in Medicaid. why that might be, and that 10% part of it is, that 10% share is part of it. But the other part of it is that the funding for the population that's currently eligible for Medicaid, Medi-Cal in California, continues to be shared about 50-50 between states and the federal government. And there are a lot of people who are eligible under today's rules, but not enrolled. And so there's some concern that as we get to 2014, as the word gets out and it is easier for everybody to find some option, more and more of those people who are eligible under existing rules may enroll, and that could have some state cost associated with it. So I want to share a few updates from my perspective again, and these are selective. The state has done many, many things and many people have worked very hard to try to advance the implementation of the Affordable Care Act in California in the years since 2010. But here are a few highlights in terms of legislative action that I thought I'd start with. The legislature enacted law to establish a state-based exchange in California in 2010. At the end of the Schwarzenegger administration, and California was, in fact, the first state to implement or to establish an exchange following the ACA. California's vision of an exchange includes some characteristics that not all states are pursuing. So in particular, California's exchange is established as a selective purchaser. That means that it won't sell every insurance product from every carrier in the market. It's going to establish standards and select plans based on criteria. The language in the law says something about the optimal combination of quality, cost, ease, and something else. But there are criteria, and they will make those real as they go through their health plan contracting process. The California law provided the authority to standardize the products sold within the exchange, and just last week, some additional information about what those would look like came out from the exchange. And that, from a consumer perspective, is a helpful step based on where we stand today, because there are a lot of different products in the market. They vary along many, many different dimensions. It can be difficult to compare and know why you might be seeing differences in premiums and whether those are related to value for you, the consumer, or related to other characteristics. There have been a lot of short-term reforms that the legislature has enacted. So in addition to this big sweep of change expected in 2014, there were many short-term changes in the Affordable Care Act too. Expansion of coverage for dependents up to age 26, changes to the elimination of lifetime limits in individually purchased coverage, and other things. And the legislature has acted on some of those. One feature of the law is that the ACA requires that all plans in the individual and small group market provide essential health benefits, and that includes those offered through the exchange. And the essential health benefits included some categories articulated in the law, but the specifics were left to the Secretary to determine, the Secretary of Federal Health and Human Services. And she, in turn, made the decision that states should choose among a certain number of options. And California made that decision, enacted legislation last term that pegged California's essential health benefits to a Kaiser small group plan that's currently marketed, and with some additional details and some refinements. There's currently a special session of the legislature going on. What makes it special, you might ask? A special session means that some of the procedural rules are altered, and that when legislation is enacted, it can take effect more quickly, which is important given the very accelerated timeline that we're on right now. And some of the unfinished business that is expected to be taken up, and it is in fact being considered now in the special session, involves codifying the Medi-Cal expansion that is envisioned in the Affordable Care Act, and enacting rules in the individual market that bring California into conformity with all of the rules that are articulated in the federal law. And that's important because while the federal law says certain things like there's guaranteed issue, all health plans have to sell to all comers, states have traditionally regulated insurance. They're the ones that monitor and police the actual buying and selling of insurance. And in California, there's a long history of having state statute on the books as well that says what the regulators can do and how they'll do it. So those are two big agenda items that are currently being considered in California, and clearly a lot of people have a lot of interest in seeing how that unfolds and contributing to making it right. So that was on the legislative side. Moving now to implementation on the side of the administration and the exchange. Just a few highlights here. The California Exchange is now known as Covered California. It has been actively meeting and working hard on a number of fronts for 2+ years now. They just recently received a large grant from the federal government called establishment funding. This most recent grant was $674 million that will see them through their operations and their startup marketing and activities through 2014, at which point they become financially self-sustaining. So the expectation in California law, very explicitly stated, is that Covered California cannot be a draw on the state general fund. Instead, it will be financed through assessments on the health plans that are sold inside and outside the exchange. A major undertaking for the exchange, for Covered California, and for DHCS, and I'm sure you'll hear more about this from Len, is to develop an enrollment system, a welcoming means by which people can find what program they're eligible for and enroll in it, whether it is a subsidy program available through the exchange, or whether it's enrollment through Medi-Cal, or whether it's telling them that neither of those is an option for them and here are their alternatives. And that is a huge information technology challenge, and certainly there's been a great deal of work and investment in that to date. Our regulators, the Department of Managed Healthcare and the California Department of Insurance, are working through the implementation of all the new rules that are required. We heard from somebody this morning, I can't remember if it was John, about the medical loss ratio requirements. And every one of these requirements is something that, to make it real and to implement it, requires work on the part of our government agencies. And then, of course, all this work you could characterize as being a little bit behind the scenes. Knowledge about the Affordable Care Act and the major expansions that are coming is not widespread, not complete among Californians. And so a significant effort around outreach and marketing is planned and will need to be undertaken in the coming year. Certainly, Covered California is going to invest in that. Other foundations, most notably the California Endowment, will likely invest a great deal in that effort as well, to try to get the word out and let people know that there are new coverage options and new obligations coming up for them. So, in summary, California has moved quickly and has invested a lot in preparing for ACA implementation, and is arguably ahead of most other states. And yet, the amount of work to be done, I think, is very substantial and significant. And because it's such a complicated law, because so many people are doing so many different things, it seems to me inevitable. I certainly raised my hand with the chaos side of the spectrum this morning. It's inevitable that it's going to unfold over time. And so some work that CHCF is investing in is a framework for monitoring, you might say, the impact of the Affordable Care Act, but I think a better way to characterize it is a framework for monitoring some of the key components of healthcare coverage and access in the state in the era of the ACA. This is work that we did with a grantee at the University of Minnesota, the State Health Access Data and Assistance Center, and that we have vetted with stakeholders, and that we think will be a great way for us as an independent foundation to contribute to sort of keeping our eye on the ball about what is it in the era of the ACA that we hope to accomplish, and what is it that is actually happening. So this framework is divided into three big areas, and I'm not going to go through all of these. They're in your slides. But the domains are basically around insurance coverage, who's uninsured, who's getting coverage through public programs, who and what characteristics do employer coverage have, and what's going on in the exchange. Some of these data points are things that will be collected administratively. Some of them we will collect through surveys or with partnerships with people who are already doing surveys. And a few of them we're going to invest in some new administrative data collection approaches where we really hope that some support for state partners and some commitment to making that data widely and openly available can put everybody in a better position to understand how we are doing in the era of the Affordable Care Act. So that's insurance coverage. The second domain out of 3 is the affordability and comprehensiveness of coverage. So it's actually very hard right now to know how many people have what levels of coverage in this state. Not so bad with employer-based coverage, but in the individual market, it can be very difficult to know. And we look forward to working with state partners and maybe with health plans as well to get a little bit better handle on what's being bought and sold through the exchange and in the rest of the market. So we understand whether people, by and large, are how much they're paying in out-of-pocket costs and so on. And then the third domain is access to care. And I think it's widely agreed that coverage is an important means to an end, but it's not the end itself. You know, coverage is associated with better outcomes and better quality of care, but you need to have access to providers. You need to have appropriate care to get there. And so through this monitoring framework, we'll be keeping an eye on both individual access to care, use of services, reported barriers to care, as well as some system components that reflect how access to care is doing. Both physicians who say they're accepting Medi-Cal, of course, but also potentially looking at more non-traditional measures of access to care. Do people have access to email consults or telehealth, perhaps, if that's, as time goes by, a good substitute for some of those types of care? So that takes me to my last slide around forecasts. And again, some of these are probably a little basic, but perhaps bear repeating. So this is a big important law. I'm certainly biased because I've been working on health insurance issues for most of my professional career, but it stands to bring huge benefits to a lot of people if it's implemented as envisioned, and if we can get through the inevitable growing pains that will be associated with all of its complexity. There is no doubt in my mind that its implementation will be a work in progress for many years. Observers of Medicare, I think, would say a work in progress still. There will always be things that can be improved and that will be changed. The level of, we start with people in a very different place. Some people are uninsured, will have new options. Some people are participating in the individual market now, will have new options. Some people, depending on where their starting point is, are going to be very surprised by how much health insurance costs and by how much out-of-pocket cost sharing they have, even once they have a health insurance policy that meets the standards of the federal law. So there's going to be some adjusting and push and pull on that, I think. People aren't necessarily used to and expecting that they will get coverage and that they will be obligated to get and pay for coverage. And so my observation here is that having some kind of shift in the conversation about what our shared obligations to one another are and why it is that health insurance may be a good value for you and a right thing to do is important. But it won't be enough to get everybody covered. If the products themselves aren't affordable and aren't providing value, then we'll be back to another iteration of this conversation before too long. Always a question, and at an economics conference, the question of who pays and how much it costs and what do I get for what I pay is always going to be a source of tension and push and pull. That plays out in many ways between state and federal government, between individual consumers, between plans and providers, always an issue to keep an eye on. And then finally, for all those cost-related reasons, the final maybe truism is that the sustainability of this whole enterprise fundamentally is going to depend on the healthcare delivery system and the way we pay for care and how much care we deliver. And unless some changes and some traction really gets underway there, again, we'll continue to have this problem about providing a promise of coverage that may not be affordable forever. So those are my remarks, and I appreciate again the opportunity to be here.